Good afternoon all. Welcome to the afternoon session. I'll be starting off with radical prostatectomy nerve sparing technique. Nerve sparing radical prostatectomy. In the words of Ashutosh Tiwari, he is the famous robotic surgeon in the United States. It's like brain surgery in the pelvis. It's because these nerves are so delicate. They surround the prostate and they lay behind the prostate like a hammock, giving support to all the structures, also supplying the external urethral sphincter and the nervi erigentis, which is responsible for potency and erection. So in this session, I'll be going through a relevant surgical anatomy for continence and nerve preservation, comparing the nerve sparing planes, operative procedure sequence, and how we preserve continence by different techniques. Finally, a vesico-urethral anastomosis and outcomes following the procedure. Now, if you see the key anatomic structures which need to be preserved are, one is the urethral rhabdosphincter, which is the external urethral sphincter, puboprostatic ligaments and endopelvic fascia, which gives support to the bladder and the prostate, the neurovascular bundles, the bladder neck to be as narrow or small as possible, and a good membranous urethral length, which is the single strongest predictor of early continence recovery. So if you see, the prostate is surrounded by the prostatic capsule, and then it has got a layer of the pelvic fascia. It is the visceral layer of the levator fascia, and the parietal layer of the levator fascia goes around the levator ani. So between these two fascias of the levator ani are the neurovascular bundles. Posteriorly, we have the denonvillous fascia, which separates the prostate from the rectum below. So if you see, as depicted in this picture, it is not like the neurovascular bundle is only at the base of the prostate. It surrounds the entire prostate, and it is not limited to the posterior aspect alone. And the composition of these nerves, they are both somatic and autonomic nerves, which are coming from T11 to L2 as well as S2 to S4. The clinical relevance include that the bundle proximity to the capsule varies by the location. I'll be telling you how during the surgical procedure, how we can damage the nerves at the prior step, and though we have done a very good nerve sparing during the prostatectomy, he may still not have any benefit of it. But basically, nerve sparing should not compromise oncological outcome. That is, in the trifecta, oncological outcome is predominant. There should be no cancer cells in the tissue, R0 resection. The next is continence, and the next only comes potency. So in oncological control, if you see wider excision, it reduces the risk of positive surgical margins, but at the expense of damaging the nerves. Now, functional preservation requires nerve sparing, and the nerve sparing can be done only in tumors which are amenable to it, which are seen on a multiparametric MRI prior to the procedure. The side where there is evidence of extra prostatic extension or there is perineural invasion, that side we are not supposed to do a nerve sparing. So basically, if you select patients for nerve sparing, patient should be having a preoperative erectile function. That is the main thing. He should have baseline continence and good voiding status, preferably a young male with minimal comorbidities. So clinical stage, it should be a localized, and depending on the location, if it is more peripherally located, the nerve sparing becomes more difficult on that side. And higher the grade, better not to do the nerve sparing on the side of the high grade tumor. The multiparametric MRI which we have seen gives us multiple clues to this. It gives an anatomical picture of the capsule, whether it's involved or not, and how far beyond the capsule the growth has extended. That is the extraprostatic extension near the neurovascular bundle. Many risk stratification nomograms have been there, like Partin tables or the other nomograms which estimate the extracapsular extension risk. But I think more than the Partins or the nomograms, the most important thing which decides whether we can do a nerve sparing or not is a good, thorough review of the multiparametric images. So we share the decision making with the patient regarding the function vis-a-vis the risk of positive margins. So there are various grades of nerve sparing. Basically, a grade 1 or a level 1 nerve sparing is something called as an intrafacial dissection. So we have the levator fascia, which has got a visceral layer surrounding the prostate, and the parietal layer which is surrounding the levator ani muscle. So if you go before or below the parietal, below the visceral fascia of layer of the levator fascia, that is what gives what is known as level 1 nerve sparing. That means majority of the nerves are spared, removing only the prostate alone. But most commonly what we do is a level 2 nerve sparing. The degree of levels, visually how we make out is the veins. If the veins go towards the lateral wall, that means we have done a very good nerve sparing. If the veins go along with the prostate, that means it is a level 3 nerve sparing. And in cases where there is extraprostatic extension, probably we will not spare the nerves on that side at all. So choose the dissection plane wisely, whether it is intrafacial, interfacial or extrafacial. So basically intrafacial is level 1, interfacial can be level 2, and extrafacial, that is below the denominal fascia, lateral to the pelvic levator fascia, is a level 3 nerve sparing. And majority of our tumors come in this region because our patients who come to us are mostly with the intermediate or equivocal imaging findings, and very early patients coming to us is rare, but it is improving, yes, because of improved screening techniques, patients being detected with prostate cancer only on elevated PSA. So we can do a very, very good nerve sparing in patients who come to us early with a very localized prostate cancer. The maximal margins of safety is obviously extrafacial, but it is reserved for patients with a palpable disease or suspected extracapsular extension or a nerve bundle which is adjacent to the tumor. What are the core principles? 1. Athermal dissection. Minimal or no use of cautery, whether monopolar or bipolar. Antegrade release or early release of the nerve bundles from the apex to the base. Selective hemostasis. Either use clips or Hemolog or very minimal bipolar cautery if you get a micro bleed to control the bleeding. And minimal traction. The more you give traction, the nerves go into neuropraxia. So minimal traction, athermal dissection is the core technical principle for preserving or having a good nerve sparing procedure. So there are basically two goals. One is nerve sparing for potency and nerve sparing for continence. Most of the dissection which is athermal or energy free along the prostatic capsule anteriorly is usually responsible for nerve sparing dissection, which is responsible for potency. It preserves the cavernous nerves. And for continence preserving, the most important factor which I had told earlier is functional urethral length. Bladder neck sparing, keeping the bladder neck as narrow as possible when it is oncologically appropriate only. A Rocco stitch, which is shown to add to continence, and tension-free anastomosis, and anterior suspension of the bladder neck to the pubic periosteum, which suspends the bladder and the vesicourethral anastomosis to give it more support. So I'll be going through a few operative steps. From the time we have started, we do what is called as the posterior first approach. We don't do the anterior first approach. The advantages of the posterior first approach is we go in and tackle the seminal vesicles and the vas early. We can get into a good facial plane because the bleeding is very minimal, and it helps us when we drop the bladder and come from above to go exactly at the junction of the bladder and the prostate. So it starts off with the posterior peritoneotomy, almost 2 to 3 finger breadths above the rectal fat and the pouch of Douglas, which is very easily seen from inside in the robo. The vas is dissected bilaterally, and when we clip the vesical artery, we can use either a bipolar or a hemolock. Second is dissecting the denonvillous fascia, as I said, whether it is extrafacial, where we go below the denonvillous fascia, where the perirectal pad of fat is exposed, interfacial between the two fascias, or intrafacial above the denonvillous, or very close to the capsule of the prostate. Now, advantage of this is early posterior exposure improves visualization of the nerve bundle before the pedicle bleeding can obscure it. This important factor is also utilized in the Redzius sparing technique, where the entire prostate is done from behind, not dropping the bladder at all. The next step is the bladder neck after dropping the bladder. Anterior dissection, go into the bladder, identify the bladder neck, cut into the posterior aspect of the bladder, go posteriorly, see the vesicles, seminal vesicles and the vas which have been dissected earlier, and then get the pedicle control. The last is the apical dissection and urethral transection. The very important aspect of this part is you may have done a very good nerve sparing everywhere, but if you hurry the procedure here, then you have done no good, because both the sides, the nerves converge at the apex. So you need to make sure that you push away the nerve fibers at the apical margin to actually do a very good nerve sparing. So what is the checklist? Functional urethral length at the apex, preserve the puboprostatic ligaments and anterior fibromuscular support. This is called as the Hood technique. Posterior musculofacial reconstruction, which is the Rocco stitch. Anterior suspension of the vesicourethral anastomosis of the bladder neck. Keep the bladder neck as small as possible, and a tension-free vesicourethral anastomosis. So I will show you a video of these steps which I have mentioned earlier. So this is the robotic position. We have an assistant 12mm arm in the assistant port in the right side. Patient is in low lithotomy, Trendelenburg, deep Trendelenburg position. Once the robo is docked, you can see this is the posterior peritoneectomy. The right side was. The seminal vesicles, artery to seminal vesicles being clipped. If you want to do diathermy in this region, you need to do a bipolar very close to the seminal vesicles. The same procedure being done on the left side. And you can see this is if you see, This is the Denon-Villiers fascia. If you open between the two layers of the Denon-Villiers fascia, this is known as interfacial dissection. If you go below the Denon-Villiers fascia, then it is extrafacial. If you go above the Denon-Villiers fascia, this is intrafacial. So this structure is so clearly seen when we go ahead with the posterior approach first rather than the anterior approach. So the entire in the rigid sparing technique, the entire operation is done from the posterior approach only. Here we are dropping the bladder. You can see the dexterity with which the instruments are working. It's almost like you're using your hands but through a laparoscopic port. So robotic surgery has revolutionized urological surgery, especially in these deep pelvic areas where vesicourethral anastomosis was a nightmare and still is a nightmare if you have to do either laparoscopically or open. So this is the standard lymph node dissection being done on either side. So usually if it is on PSMA PET CT, it is not involved, and if it is a low intermediate grade tumor, operator node dissection is sufficient. Here this is the bladder neck being cut. We have entered the bladder. You can see the catheter inside. And we cut the posterior bladder neck early to keep the bladder neck as narrow as possible. So we have entered posteriorly. This has already been done. The dissection has already been done. So it's easy to identify the vas and seminal vesicles. This is the pedicle which is being clipped. So one important aspect of clipping this, when you clip the pedicle, you clip it closer to the prostate rather than closer to the bladder. This is the area where the base of the prostate, where the nerves come around to surround the prostate. So if you keep your clip very close to the bladder, you invariably ligated the nerves, and when you cut it, you have cut the nerves already. So no point doing a nerve sparing beyond this. So you can see the nerve sparing part. This is the left neurovascular bundle being dissected off the prostate. This is the right side.
May I request the speaker to kindly begin concluding the session in next 5 minutes, please?
Yep. So that is the right side pedicle being divided. So you can see again that the pedicle is divided very close to the prostate here to preserve nerves maximally. This is the posterior dissection. Now as we come anteriorly, previously we used to put something called as a DVC stitch. Nowadays with the air seal or the positive pressure insufflation, we don't need to ligate the DVC prior to cutting the urethra. So here you can see this is the posterior urethral plate, this is the urethra, and you can clearly see the rhabdosphincter. This is the DVC. Just below that you can see the muscle layer, this is the rhabdosphincter. This needs to be preserved, should not come into your stitch to preserve maximum continence. The DVC is ligated. And this is something called as a Rocco stitch. That is, we approximate the cut-ends of the Denon-Villiers fascia to bring the bladder closer to the urethra to prevent tension on the vesicourethral anastomosis. So the vesicourethral anastomosis taking place, we use a suture, barbed suture called as Stratafix. We go continuous running sutures on both the sides. And at the end of the procedure, we check by filling the bladder. So this is the robotic assisted nerve sparing technique. This was done just 2 days back. This is known as hydrodissection. We are injecting saline in the underneath the capsule of the prostate. The advantage of this is you can see clearly which level you are going. You can see this is almost the capsule of the prostate. This is the maximum nerve preservation which is happening here. So this is one of the recent techniques. Still studies are going on regarding using the, you can see this structure here. That is one of the nerves. If you go closer on the robo with 30x magnification, you can actually visualize these nerves. The rest of it is the same. As I said, clipping it closer to the prostate rather than the bladder. And very commonly there are something called as capsular vessels which bleed ferociously, so it's better to clip them before cutting. For preservation of nerves during radical prostatectomy. So different techniques. One is the red-jet sparing, as I said, posteriorly, totally posterior. One is the hood technique where we preserve the puboprostatic ligaments, and then the standard robotic assisted radical prostatectomy. All three were studied. The continence preserving, the 3-month continence rate was almost equal for the red-jets and the hood, although it was marginally better for the red-jet sparing. But the disadvantage of a red-jet sparing is more positive margins. That is not good. So continence recovery time, it is measured by pad-free continence rates. At 1 month, approximately 50%. At 3 months, approximately 70%. At 6 months, approximately 85% should be continent. It all depends on what is the age of the person, the basic baseline pelvic strength, the preserved urethral length, and the surgeon experience. So in one slide, if I have to put a key takeaways, the location of the nerve bundle which runs posterolateral to the prostate between the prostatic and the lateral pelvic fascia. Select the right patient whom to do and which layer to go, whether intra, inter or extrafacial. Athermal as far as possible, minimum stretch on the nerves, and patency and continence both improve even up to 24 months post surgery, but cancer control is never traded away. So the main thing is good oncological clearance, the next comes continence, and the last comes potency. Thank you.
Thank you, Dr. Karthik, for that detailed and technical enriching presentation. Now the floor is open for Q&A. I request delegates to please keep their questions brief and focused so that we may accommodate as many questions as possible.
Post-lunch session, I think I put people to sleep. Anyway, it's a very it's a passionate surgery for any robotic surgeon to do a good radical prostatectomy. It includes me. It is one of.
Excuse me, sir.
Yeah.
Sorry to interrupt.
Yeah,
I
please.
have a question. Do you really wait for 6 weeks these days after the biopsy before radical prostate? Because in my center nowadays we are just waiting for the biopsy report and the next day patient is taken in.
Yes,
and we have found that it's being useful. It's not getting
the
fibrosis.
issue is it is waiting for 2 weeks prior post biopsy for doing a procedure. That concept is going away right now, including in AUA conferences. Post biopsy, immediately 2 days or 3 days post biopsy, people are still doing it, and we have not found any difficulty in doing procedures as early as 2 days also.
Okay. Thank you, sir.
If there are no questions, so basically we charge 1.5 lakhs extra than a lab procedure. That means because we use 4 instruments, it's going to charge the patient around $1.5 lakh. So if you have to do a robotic radical prostatectomy in our center, it could cost between 4 to 5 lakhs. Advantages: early recovery. Patient usually go home by the 3rd or 4th day. The earliest we have sent is a patient on the 2nd post-op day. If there are no more questions, I'll hand over the floor to Shubha. Thank you.
We now move on to our next session. Robotic radical cystectomy with intracorporeal ileal conduit. This session will address the key operative outcomes, including cystectomy, pelvic lymph node dissection, bowel segment isolation, ureteroileal anastomosis using the Bricker and Wallace techniques, and the stoma maturation. I request Dr. Santosh Subudhi sir to take over the podium.
Good afternoon, ladies and gentlemen. So, I am Dr. Santosh Kumar Subudhi, consultant urologist at Fortis Bannerghatta Road. After discussing about radical prostatectomy, I'll discuss about radical cystectomy, which is a longer procedure, and the presentation also might take a bit longer time. And I will tell you detail because this involves bowel, so it might take a bit longer time for the procedure. So, welcome to SURGX 2026. So, I have created a roadmap where we will do a structured curriculum where I will tell you how the patients are being selected, how they are worked up, what is the operative technique, and what are the outcomes. So, carcinoma of the bladder is the 10th most common malignancy worldwide, and every year 6 lakh cases have been detected, and in India it is the 10th most urological cancer. So, if it is so, then what are the indications for doing a radical cystectomy in a CA bladder? These are muscle invasive bladder cancer, which is the primary indication, and if it is a high risk recurrent non-muscle invasive bladder cancer, which is refractory to BCG, or the patient is BCG unresponsive, or there are any variant histologies like micropapillary, plasmacytoid, or neuroendocrine elements, then you do a radical cystectomy, or it is a palliative one if the patient has hematuria or pain, intractable, and or he or she has developed a fistula. So the evolution of the radical cystectomy with ileal conduit towards robotically totally was recent one. Earlier, first radical cystectomy was done by Bernard in 1887. After that, till 1949, the ileal conduit was not done. Till then, because the urine has to be bypassed, so they were doing cutaneous ureterostomies or ileosigmoidostomy. But after the ileal conduit was done by Bricker in 1949, this was the gold standard for decades, where people were doing open radical cystectomy with open ileal conduit. But till 2003, when Dr. Manimenan first attempted to do the robotic radical cystectomy, it was a success, and they named it as the Verticuti technique. After that, the next thing is, after radical cystectomy done robotically, ileal conduit was also attempted to do, which was started in 2010 only. There was the paradigm shift, and in 2018 the RAZOR trial was released, and then it was shown that the robotic radical cystectomy is not inferior to the open one. The outcomes were almost the same. And for the ileal conduit intracorporeal, there was also a study which was called as IORC trial, which also showed that the intracorporeal ileal conduit is equally better in higher volume centers. So what are the advantages of the robotic radical cystectomy? this, because the robot has 10x magnification, so you will be having better vision of the bleeding and also the nerves, which Dr. Karthik told. You will, as in a lab you have tremors, you will not have tremors in this. And you can go deep into the pelvis where your hand cannot reach, the robotic hands can reach. Also, there is 7 degrees of freedom in the robotic arms, where the endo-wrist articulation can be done for suturing in the pelvis for the all the structures. Like in radical prostatectomy, it helps you for the vesicourethral. Because of the good vision, the loss of blood is also less, because once you see a bleeder, you can directly do that with enhanced magnification. So the blood loss has reduced from around a liter to 200 to 300 ml. And because you are doing a minimally invasive surgery, the recovery is also fast, where earlier when open cases were done, it was 10 days, 2 weeks the patient had to stay, but now it is only 5 to 7 days. So who is the right candidate? I have already told the indications, but who shouldn't be done are, these are the contraindications, where the GFR, if it is less than 40, because you use bowel to bypass the urine, so you should have a GFR of more than 40. Hostile abdomen, where multiple surgeries are done, there where you cannot use the ileal conduit to be put. If it is morbid obese, then because this surgery needs a surgery in the pelvis, so you have to place the patient in Trendelenburg position, like in radical prostate. So the patient cannot tolerate the steep Trendelenburg if it is a morbidly obese. And if there is any bowel disease and you cannot use the bowel for a conduit, then you need to avoid that. So when the decision has been done, so you have to counsel the patient. In this, you have to sit with the patient and their family members to tell them what is the functional outcomes. You have to tell that there will be a stoma which will allow the urine to come out. It will deshape or defame the body, but this is the right thing to be done. And also has to be told that you will have a altered sexual function. So you have to also involve a stoma therapist before the surgery, where they will come and mark the site of the stoma, and they will tell that pre-operatively only, that after the surgery has been done, how to take care of the stoma. So patients with ileal conduit and neobladder, if you compare, because in neobladder you have an intracorporeal thing, you don't require anything externally, but you have to tell them that there are few reasons, like if the margin has been positive, or many other reasons like the contraindications which have been there, then we have to tell them that this is also equally effective. So this is a new thing which is coming, is the enhanced recovery after surgery. This is the ERAS protocol which we have been following, where you make the patient pre-operatively, intraoperatively and post-operatively to do some things which will make the recovery of the patient fast. Like in pre-op, you can give the patient carbohydrate loading up to 2 hours of surgery. You can optimally nutritionally optimize the patient with good albumin levels. You have to ask the patient to have a cessation of the smoking, because post-operatively you will require a lung rehabilitation, and bowel preparation if it is required to do any colonic surgery, or else for a ileal conduit it is not required. Intraoperatively, you have to direct the patient for fluid therapy. You need to use totally intravenous anesthesia, and to avoid a nasogastric tube if it is so, but sometimes we require, because you have to decompress the bowel. And post-operatively, you can give the patient oral fluids as early as possible. After 6 hours, you can start using diet, soft diet initially, and then liquid diet initially, then soft diet, and then solid diet within 24 to 48 hours. Ask them to use chewing gums for not allowing the ileus to develop, and make them early ambulation within 12 to 24 hours, and give them a multimodal analgesia which will make them to ambulate early, so that the bowels will also move early. So in the ERAS protocol, it reduces the median length of stay of the patient to 5 to 6 days, which was 10 to 14 days earlier, and the complication rate also reduces if the ambulation is early. So in the preoperative evaluation, like we do other patients, we have to do here also. We have to do a preoperative imaging for the staging, which we use a contrast-enhanced CT and a PET CT for the metastatic workup. In the laboratory, all routine has to be done, but the most important is the GFR, where you know that if the GFR is more than 40, you will do it. If it is less than 40, you will not do it. You will optimize the patient, where the hemoglobin should be beyond 10, the albumin should be beyond 3.5. You should start with DVT prophylaxis, and you should give a good preoperative antibiotic. The stoma marking is the last, but this is done by the stoma therapist, where they will come, speak to the patient, mark the area where you have to make the stoma outside. Then after this, the patient is taken to the theater, where you will have to start the surgery, so you have to position. After the anesthesia has been given, then you have to do the positioning of the patient, which is the Lloyd Davis position, which is the lithotomy position. You have to keep the arms tucked bilaterally at 15 degree, keep it in a steep Trendelenburg, which is around 25 to 30, and then use the shoulder braces, because you're keeping in Trendelenburg position, the patient shouldn't slip down or fall, so you have to save the patient. Then after all this is done, you have to put a catheter so that the urine is continuously drained, and if required, and a nasogastric tube can be put. In all these surgeries, in the open surgery, the surgeon stands near to the patient, but here the surgeon sits on the console, but besides the patient, you make an assistant to help you for all the suction, applying clips, applying staplers and all. Other scrub nurse is near to the trolley, because he will hand over, or he or she will hand over to the primary assistant. Then instruments. So what are the instruments we use usually for the radical cystectomy is the bipolar Maryland, monopolar scissors. You use a needle driver. You need a vascular sealant, because that will help you for the bowel resection, and then use the staplers for cutting the bowel. You have to have a camera. You have to have a progress for retraction. So in XI system which we are having, it has a longer reach, and it reduces the collision between the other arms, so that you will have good orientation, and then the articulation of the arms will be better in that pelvic area. So in this, what we do is, we put the ports. The camera port is 8 millimeter just above the umbilicus. In the midline, you have a right iliac fossa first arm. You have a port right to the camera second arm, and the third arm is left of the camera for the bipolar Maryland. You put an assistant port on the left side. In radical prostate, you put the port on the right side, but in this, you have to put on the left side, because you have to do the bowel work. So it should be easy, and if you do on the right iliac fossa the assistant port, then it will be difficult. And other assistant port which is there, it should be above the supraumbilical, where you have to push the sutures, or you have to use some retraction. So if all these are there, then there can be there can be collision between the arms, because robot has 4 arms, and you have to avoid the collisions. So how will you do? You put at least 4 finger breadth in between the ports, and target the port placement in a single horizontal line, angle the arm cephalad after cystectomy for the conduit, and avoid external arm crossing. You resign arm functions dynamically. So in XI system, it enables rapid redocking, because it's a single boom which is there, where the arms are there in one place, and then you can put it so that you can reposition for the ileal conduit also, and it will avoid wasting of time. So this is the port placements which I have shown this. And this is the steep Trendelenburg position, 25 to 30 degree, which is there. You have seen this. So we will start after this. You have to dock the robot after the ports have been placed. Then you start the surgery. The initial steps are the exploration and the sigmoid mobilization, where you do the peritoneal mobilization on the left of the sigmoid colon, where you medialize it, and then go and see up to the ureter, and then identify and hook it up. And once this is done, the opposite side of the opposite side also the ureter is identified, and do it. You have to keep adequate periureteric adventitial tissue to allow the good vascularity of the ureter, so that later part it doesn't get necrosed. So then after the ureters have been identified, we dissect the posterior one in the pouch of Douglas and separate the Denon-Villiers fascia. So the rectovesical pouch dissection is done. The peritoneal dissection between the bladder and the rectum is incised transversely. This is in males, but if it is a female, then you have to do the anterior exentration, where the uterus, cervix and the anterior wall of the vagina is also being taken out. So after this is done, then you come to the lateral pedicle control and the endopelvic fascia, where the hemlock clips are used to clip the vascular pedicles, the superior vascular pedicles, and then the bladder is separated from its vascularity. Then the lateral attachments are being dissected, where you have to incise the endopelvic fascia, and then you have to go and sweep it laterally so that it is getting separated, and then once this is done, you go towards the DVC. After everything is being done, then only remaining behind the attachment with the body is the deep DVC, or the deep venous complex, dorsal venous complex, where you have to either cut it and then suture, or you can take a suture and cut it. All is done, then only the bladder with the urethra is bladder, prostate and with the urethra is left. So you will have to mobilize the DVC above, separate the prostate, go up to the urethra, and then you will have to cut the urethra at the level of the prostatourethral junction, so that you are not going far, because this is not prostatic malignancy. You can take at the apex of the prostate, so that you will not hamper the control sphincteric mechanism, and also the anastomosis will be better. But all these are there, but you shouldn't make the oncological outcomes at stake. So you have to see that, you have to send that margin for biopsy to see that it is negative, and then you can proceed. After all the specimen is being cut, you have to bag that specimen and then keep it aside. In all these, when you're cutting the anterior urethra, you need to deliver the catheter and then clip it, so that you can hook that or pull the catheter, and then whatever the malignant cells are there, you are trying not to displace those malignant cells into the peritoneal cavity. So you have to hook it and pull it. So this is the one video I am showing. I'll show you 2-3 videos, but earlier we were doing in a different technique. We have changed the technique, where we are trying to hook the ureters, and then doing in between the lymphadenectomy was also done, but we have changed our technique. We are completely doing the cystectomy part and then doing the lymphatic part. So this is the left ureter which is being identified. The vessels around it have been cleared, and then you have put a clip. So this is, now it is coming to the right ureter. Usually once you do that, you have to send the margins for the biopsy. Whatever the vascularity comes along the ureter up to the bladder is being traced, and then it is being either cauterized or clipped and cut. And at the end, near to the bladder, you cut that ureter after clipping it. Now, because this is a female patient, you have to remove the uterus also, so the dissection is being done, and posteriorly, so that, and you dissect up to the whole of the anterior vaginal wall and you cut that. Now coming to the anterior dissection, where you need to make the bladder to fall down. So you are going up to the space of Redius, you have found that, make the bladder to drop down. The left side is the vascular sealant, where it will try to hemostasis, see how it is nicely doing, sealing the vessels. And then you cut off the anterior vaginal wall from the, along with the specimen. And after all this is done, make the bladder to completely fall down anteriorly and then cut over the urethra. In a neobladder, the urethral margin is usually sent for biopsy and see that it is negative, but in ileal conduit also we see that it is not required, so the total urethrectomy is being done in a female. And after that, you close the vaginal cuff with the peritoneum. So this ends the cystectomy part in a female. This is in a male, where the similar thing is being done. You identify the ureters, go along with it. The left ureteric dissection is being done. Identify up to the, or dissect up to the bladder and put a clip, put one more clip proximal to it, and then do it. I don't know whether it is the same video going on. So, sorry, that was the same one. So this is the medial umbilical ligament which is being cut. And after you do that, you identify the ureters. And then now you clip the ureter, you cut it in between, and then send that margin for biopsy. So this is being sent. And then the posterior dissection is being done. You can do variations of many, whichever you are comfortable. And now the right ureter is being done. Similar way, you have to clip it, cut it, and then send the margin for biopsy. And in the similar way, because this is a male, you will do the prostate dissection, go beneath the prostate and the seminal vesicle as far as possible. And then the anterior dissection, it is the same. But here, because it is a male, you don't have to do anything anterior to it, because you will have to directly get the prostate and you will get the DVC. In female, the vaginal cuff has to be dissected along with the uterus, and then you have to cut it. And then the DVC is being cut and ligated. This is the other part where we can do the dissection of the lymph nodes at the same time, but we have changed the technique. Here it is showing that we are doing the dissection of the lymph nodes in between. The same ureteric dissection has been done. And then you send the margin for biopsy. You put a suture along with it to identify the ureter for this, and in this I wanted to show that you're bringing the ureter to the opposite side to see that the length is adequate. You take the periadventitial tissue around the ureter, you dissect as much as it is required so that the vascularity is maintained, and then the posterior dissection is being done. In this, after this, you can go and directly go up to the urethra, finish the posterior dissection, you go up to the lymph nodes and then dissect the lymph nodes at this point of time also. But because the bladder is still there and it is always hanging, you see the left hand is struggling, you are trying to do that, difficulty in the lymph node dissection will be there, so we have changed our technique. This is the lymph node dissection which is going on. We have not dropped the bladder yet. Now the lymph nodes is being dissected and separated. These are the this is the vessels and this is the obturator nerve. These are the vessels and this is the obturator nerve. So this is the one of the variations. So next is the EPLND, where you have to do the lymph node dissection. The boundaries which are there are the laterally it goes up to the genitofemoral nerve, medially it is the bladder, cephalad it is up to the aortic bifurcation, and below is the inguinal ligament or the node of Cloquet, and posteriorly also the presacral nodes has to be removed and the obturator fossa. So the technical considerations are you should at least yield more than 20 nodes for adequate staging. Clip the lymphatics meticulously, because post-operatively there can be lymphocyl or the collection which might be troubling you later. You should preserve the obturator nerve, and you should identify each set of lymph nodes like the external iliac, internal iliac, obturator, presacral and common iliac, so that there will be no confusion and you will know what level of positivity it is there. So this is the pelvic lobe lymph node dissection in toto, but this is already been seen. This is the external iliac artery we are seeing. Laterally is the genitofemoral nerve here, and then you are going up to the obturator nerve, you will see here. Yeah, so this is the obturator nerve which is being dissected. Distally it has been separated from the Cloquet node, and then proximally up to the common iliac you do and then separate. So after the cystectomy part and the lymphadenectomy part is there, then you have to create a ileal conduit now. So for the creation of this, you need to select the bowel and then isolate it, and then the ureters has to be anastomosed. So in this, you have to take it 15 to 20 centimeter from the ileocecal junction, so that the distal ileum which is used, which is actually required for the vitamin B12 malabsorption, avoidance of the vitamin B12 malabsorption will not be there. You have to assess the vascularity of the bowel which you are taking. You see the arches with a light on that side, and then you can find out that the arches are there. At least 2 to 3 arches should be there, so that the vascularity of the bowel is maintained. You then after that you identify where you have to do the division. Then you put this stapler. Earlier we were doing endo-GI staplers, which the assistant was using. Now we also have this sure form where it is used with the robotic arm, and the surgeon himself will use this sure form to separate the bowel. And after you have separated, orient the bowel that whichever is proximal end, it should, where the ureter should anastomose, distal end should go into the abdominal wall. So after that, the bowel continuity has to be maintained. So the cut ends of the ileum has to be joined, where it is done robotically and intracorporally with the help of staplers. We make holes on the bowels, and through that the stapler is used to connect both, and after this is done, the defect is closed by another one more stapler. After the bowels have been joined, the mesentery which is there in between, there will be a defect. To avoid internal herniation, we have to close the mesentery also. And then the conduit position, which I told you that the distal segment should come out through the skin, and the proximal one should be used for the anastomosis with the ureters. So this is the bowel harvesting. So after this is done, so the ureter on the left side cannot be anastomosed with the bowel anteriorly to the sigmoid. So we have to do a sigmoid tunnel underneath, sigmoid mesentery tunnel. See, the arm is coming. So now you have identified where the ureter is with the suture which we had ligated with, which helped us to bring it out. So this is bringing out. You should see that there is no acute kink at that junction, so that the obstruction of the ureter shouldn't be there. And see, keep both the ureters placed at one place, so that you will have no difficulty in identifying later. So now you have identified the place where the bowel has to be cut. So now you have held it, now you have to use. So this is the arm of the robot which is used to clip it. This is the assistant arm. The robot sure form will be different. Now you join this, you make a holes in this, so that you have to join both of them. Now the surgeon will hold both the segments side by side. So that the bowels can be joined. So once this is done, you see that the anastomosis is adequate. This end is again fired with a stapler, so that the end gets closed. So the bowel continuity is restored now. So this is the other one. The ureter is transposed. Identifying the ureteral segment is, ileal segment is done. And now, see, this is the robotic arm, where this is the sure form, where you use it to disconnect the ileum or isolate the ileum. So this, for this reason I have shown this. You are seeing it is the surgeon is only using that arm. So after the isolation of the bowel has been done, the ureters has to be anastomosed with the bowel segment which forms the ileal conduit. So that is placed posteriorly behind, and the anterior to it is the anastomosis of the ileum which is done. Now that segment has to be picked and then brought it. Once this is done, then the anastomosis of the ureters can be done in many techniques, but in robotically 2 techniques have been used. There has been seen that there has been no advantage of one over the other, only advantage of few of the techniques like the valves is that the surgeon can do the anastomosis better, so that the complication rates will be a bit less on the valves technique. So in valves one, earlier what they were doing, they were anastomosing the one ureter to the other, and the single ureter was being anastomosed to the ileum. There the complications was, if that ureter gets affected, then both the kidneys have been affected. So in valves 2, they did that both the ureters are anastomosed simultaneously side to side, and then both the ureters are same time anastomosed with the ileum. So if there is any problem with one system, the other system is actually spared. In the Bricker's technique, this is also not there. You anastomose both the ureters separately, but it takes long time and it might be difficult also. So this is the technique. This is the valves, where you anastomose, you keep both the ureters side by side, cut open the ureter, so that it is a long anastomosis. Now you are cutting open the bowel where you want to anastomose the ureters. Then both the ureters are anastomosed at the same time. This is valves 2 type. The posterior wall of the ureters are both joined initially, and then the whole of the part will be anastomosed to the bowel or the ileum in an end to side fashion. Now each one is individually put a stent, so that the safety of the ureter and the patency is maintained. Both are being pushed through that segment where we will operate and put it in, and that will come out through the other segment. These are the ureteric catheters, ureteric splints, and then the anterior wall is again closed. We get multi-coil stents also, which we are using nowadays, where you don't need to extrudize the stents, that will be kept inside the conduit itself. This is the mesentery being closed. And after that, you keep a stray suture on the proximal end of the conduit, so that when you're trying to pull it out, it will come out easily. Or else holding the bowel with forceps is difficult. So now it is getting pulled out. You made a hole where the stoma therapist has told, you do it on the right side, hold it with the back cock and pull it. So next is the Bricker type, which I told that you individually do the anastomosis. So you have to open the ileum and the ureter. It is done in end to side fashion individually. So the anastomosis takes a bit long time. So we changed our technique from Bricker. Initially we were doing, but now we are doing valves type. Put a stent after the posterior wall is being done, and see, the stent was put and then it was put into the loop of the ileum, which was isolated, and nothing to worry about extrusion, because later you can do a scopy and of the conduit and then remove. So one side is done, the other side is being done now. After one wall is being done, you put a stent and then close the other wall. So this is called as Bricker type. So what are the important points when you are doing the anastomosis? Is you have to maintain a good vascularity. The periodontal tissue should be well maintained. You should minimize the mobilization of the ureter. See, when you mobilize the ureter and come up to the area where it has to be getting anastomosis, see that much. Don't try to mobilize the ureter proximally so that the vascularity is maintained. You do a good tension-free anastomosis, and after that you splint that anastomosis with a stent so that the anastomosis heals well, and it is kept for few weeks so that after healing the stents can be removed. So ureteroenteric strictures are common. They have seen that almost same with both Bricker and Wallace type in high volume centers. So after that you have to do the stoma extrusion, which I showed, where the mark has been done by the stoma therapist, and you mature it. You try to pout that external end so that it becomes as a rosebud, and then you evert that bud, and then it should be that the patient can do the care of the stoma properly. And then you have to maintain the hemostasis, you have to put a drain, and then do the closure of the ports. So, and in the ERAS protocol, which I have already told, which Dr. Shubha will later, tomorrow she will tell, that you on the day 0 you give sips of water up to 6 hours. You can start the anticoagulation with low molecular weight heparin within 6 to 8 hours if everything is okay. Avoid opioid analgesia so that it shouldn't delay the bowel recovery. Check the drain creatinine, because that can hamper the recovery of the bowel also. Second day you change it into clear diet, clear fluid diet, and then start chewing gum so that the ileus is not there. You ambulate the patient, physiotherapy should be done, do chest physio, intensive spirometry, everything. Drain output, if it is okay, then it is fine. If it is more, then see for the creatinine so that you can do some intervention. Third day onwards, give soft diet, and you can remove the drain if it is less than 50 ml. DVT stockings can be put. You need to see the dyselectrolytemia if it is there or not. Pulmonary function also needs to be seen. Because this is robotically done, and then you have followed the ERAS protocol, you can plan to ambulate them early, and then the bowel has moved early, then you see that you can discharge by 5th to 7th day. So what are the intraoperative complications which you need to identify and manage? If it is a bleeding from a major vessel, try to control it with the 4th arm, because you have an added arm. You need not hurry about. Put the arm on that place where it is bleeding. Keep it so that the bleeding doesn't happen. Ask the assistant to keep the suture ready. Take the suture, change the monopolar scissor into a needle holder, and then do the suturing. We shouldn't be in a hurry. And also the intra-abdominal pressure due to the pneumoperitoneum will also help you to manage the bleeding. Also we have a air seal which continuously keeps the vision. If there is bleeding also, that has an added advantage. Rectal injury, if you see that if there are any surgery done, or there is suspicious of that you might injure the rectum, you put a rectal bougie so that the identification is done, and intraoperatively you can put a finger into the rectum and also see that it is not injured. If there is any ureteric injury, then you have to cut that and see that where you can anastomose. Bowel injury, you can directly do the bowel repair immediately, or see if it is not helping, then you have to do some ileostomy procedure. So early and late complications, if it is less than 30 days, it is early, and if it is late, it is more than 30, it is late. Those early complications can be prolonged ileus. There can be a leak, which I told you need to monitor with the creatinine of the drain fluid. And then if there is any infection, then you need to take care. Lymphocyl, so that's why the lymphatics has to be controlled better so that the collection post-operatively is less. Do the DVT prophylaxis by giving low molecular heparin within 6 to 8 hours of the surgery. Late complications, it can be a ureteroenteric stricture where you anastomose the ureter with the bowel. There can be a stricture. The stoma can have stenosis. There can be herniation with like any other stoma. Also, there can be metabolic complications and vitamin B12 deficiency if the terminal ileum has been used. So, expert tips for challenging scenarios we need to discuss, because if there is an obese patient, we cannot tell that we will not operate. You need to use extra long ports where you can go into the peritoneal cavity, because the depth of the skin and the subcutaneous fat will be too much, so you have to use the extra long ports. You have to reduce the Trendelenburg position. You need to use the deep vein thrombosis prophylaxis early. If it is a male narrow pelvis, then you have to do the extension of the robotic arm. You have to use the zero lens for apical dissection. Early endopelvic fascia incision gives the pelvic floor access easily. You can also use Firefly to identify the neurovascular bundle and then avoid the nerves. Prior abdominal surgery, you need to see that you have to put the first needle for the pneumoperitoneum in a place where it will not damage the other organs, and you see that if there is any bowel adhesions inside, you need to release them. And if there is a blood loss, you see that you increase the intra-abdominal pressure. You try to hold with the fourth arm, clip it or suture it. So how to prevent the bowel complications is you need to avoid energy source as less as possible, because once you are using any energy, it spreads laterally up to 5 millimeter. Any strictures, you see that the ureteroenteric strictures, you see that the periureteral adventitia is always maintained so that it doesn't have loss of vascularity, and the ureteric mobilization is not much so that it will not cause loss of vascularity. And conduit ischemia, you see that the 2 or 3 arches are well maintained within the conduit so that the vascularity is good. So this is the trial which says that the robotic radical cystectomy is equally better, razor trial, in comparison to the open. And in centers where they are doing all robotically, they have seen that they have equally or more important, better results. The IORC trial, which I told you, that it compares the intracorporeal or extracorporeal formation of the ileal conduit. They say that intracorporeal also can be done and it has good efficiency. The progression-free survival in 2 years is 72% it is seen. The length of stay is reduced because you have done robotically up to 3.2 days. The complications are less because you are always seeing what is going on inside. So the reduction is 35%, and the yield also has been good beyond 20 nodes, that is 23 nodes. The functional and oncological outcomes. The oncological outcome says that the 5-year cancer survival rate is 60 to 70% for T2, and for T3 it is 40 to 50%. The port site metastasis is rare. The positive margins at the surgical site are less, 4 to 8% only. The lymph node yield is good, and node positivity is 25 to 30% in MIBC. The quality of life is either always better with the robotic, but the cost is higher initially. But if you see that to open, then the length of stay increases, then if there are any complications, all those things, then it will take more cost. So it is almost equally cost effective. So for learning curve, it is up to, if you want to become an expert in doing radical cystectomy, you have to do at least 100 cases. But before that, when you are doing up to 20, it is phase 1, up to 50 is phase 2, and up to 100 is phase 3. So this is the chart which we have already discussed. These are all take-home messages. The oncological integrity, that wide margins has to be taken so that the oncological outcomes are not hampered. The nodes should be more than 20 to be taken. Always send the ureter and the urethral margin for frozen section so that if there is any positivity, you can cut some more. You see that the vascularity of all ureter and the bowel is maintained by keeping a good periureteral adventitia, and bowel also keep 2 to 3 arches. Use systematic approach for one step after the other. Also follow ERAS protocol, and we have our anesthetists who are very much helping in doing this. So this is done. So in future directions, so you have a DV5 and the single port technique where it will be more enhanced. You use fluorescence also to identify the ureters. Your conduit vascularity and the sentinel mapping can also be done in future. AI-assisted surgical guidance will help in intraoperative anatomy, predict the hemorrhagic alert that this the vessel is nearby. You can find out and then tell that you need to be cautious in doing that area. And also the suturing techniques, the 3D printing and AR navigation, patient-specific pelvic anatomy models for surgical planning and training is also being done, where you will know that with the patient, with the AI, they will create a model that you know that this is the way you have to go forward. The in research there are perioperative immunotherapy integration, where a neoadjuvant plus adjuvant pembrolizumab has been given to see that the cancer is under control. Continent intracorporeal diversion, where robotic orthotopic neobladder at scale you can try. Biomarker guided patient selection for nerve sparing cystectomy, where it will help you in seeing that where the nerves are and you can avoid those injuries. International collaborative registries have been done for standardized outcome reporting. So robotic radical cystectomy with ileal conduit diversion at a high volume standard is the high volume centers is the standard of care. Thank you.
Thank you, Dr. Subudhi sir, for the detailed demonstration of robotic radical cystectomy with ileal conduit. Now the floor is open for Q&A. Anybody with questions, please raise your hands.
I know it was a very long and everybody is feeling sleepy. No
Also,
issues.
thank you, Subudhi sir,
Yeah.
for covering my RASP protocol 50%, so tomorrow I need not work up so much. All right. We move on to next topic, which is robotic surgery in pediatric population, focusing on anatomical consideration, port placement, procedures like pyeloplasty and ureter reimplantation. I welcome Dr. Basaraj Niliga to take on the podium.
Good afternoon, everyone. So we'll be discussing about robotic surgery in pediatric population. So as we all know, the robotic surgery has added advantages of precision and dexterity. It improves the wristed movements of the human hand. It mimics the movements of the human hand with 7 degrees of freedom. Also, it filters the tremors and in enabling, helps in enabling the fine dissection in the tight anatomical cavities. What is also important is the motion scaling translates the large hand movements into the micro movements, critical in pediatric patients because of the lack of space. Also, the visualization and ergonomics, high definition 3D binocular vision with 10x magnification, and surgeon would be sitting comfortably and operating. It takes away the surgeon fatigue. The milestones in surgical robots, the FDA approved Da Vinci surgical system in 2000. The earliest pediatric robotic case was done in 2001, a Nissan's fundoplication in a girl. And it evolved, the main hindrance was the port size. It was minimum of 8 millimeter. In next 2016 to 2024, the system expansion, 3 millimeter to 5 millimeter instruments evolved. This enhanced platform developed by Karl Storz, so which is ideal for infants also. In 2025 onwards, AI integration is happening at a very fast pace. Also, the autonomy with the help of AI guidance and haptic feedback, which is helpful for neonatal surgery also. So what are the anatomical challenges in pediatric population? One is the limited cavity volume. Infants and small children possess vastly restricted intra-abdominal and thoracic cavities. And also the proximity of the major vascular structures like aorta and vena cava and solid organs increases the risk of iatrogenic injury. It may happen while placing your port or during the surgery itself. And reduced interport distance. The Da Vinci system requires a minimum of 4 to 6 centimeter gap between the two instruments. In pediatric population, this because of the less working space, there can be clashing of the ports, or we may have to compromise with the number of instruments we use to operate. And the pediatric tissues are thinner, highly elastic, and more fragile than the adult counterparts, so we have to handle the tissues very carefully. Also, the abdominal wall thickness is minimal, and we have to be very precise in putting the ports. Then shorter working distances. Suppose if you go inside, they are very close to the operating organ. If you come out, you will be in the port. So you have a very limited working space. What are the physiological adaptations to pneumoperitoneum? What happens when we insufflate the gas? There will be cardiovascular impact. There will be elevated intra-abdominal pressure that can reduce the venous return and cardiac output. Respiratory mechanics are affected in terms of cephalic displacement of the diaphragm, decreasing the functional residual capacity and compliance, risking the hypercarbia, atelectasis, and increased airway pressures. Renal and splenic perfusion, excessive pneumoperitoneum pressures compromises renal blood flow and glomerular filtration rate. Port placement and instrumentation. Triangulation geometry, ports must be placed close together due to the small abdominal surface areas, or we have to manage with only 2 instruments. Avoiding arm collisions, external instrument shaft collisions require optimum port spacing, at least of 4 centimeter, and bedside assistance axis. Ports must allow adequate room for suction, retraction, and suture passage by the scrubbed assistant. So one more, at least 5 millimeter port is required for the assistant to help the operating surgeon. Age and weight considerations. The standard recommendation is 10 kgs of minimum weight. While the traditional robotic platforms are suggesting this one, the studies from 2012 to 22 have shown that robotic surgeries are safe even in children less than 10 kgs also. The smallest baby we have operated is 3 months, weighing 2.63 kgs. So developmental group, if in neonates and infants, if it is less than 10 kgs, extreme cavity restriction is the drawback. Low pressure limit, the gas pressure has to be less than 8, and rapid desaturation risk. Toddlers and young infants who are weighing between 10 to 20 kgs, external arm crowding is the risk, requires precise port triangulation and table elevation. School age or adolescents weighing more than 20 kgs, anatomy mirrors, adult parameters, excellent working space, and fourth arm can be used. What are the clinical benefits? Reduced postoperative pain and quicker recovery times, shorter hospital stays for complex reconstructive urology and general surgery, exceptional precision in tight spaces like pyeloplasty, colorectal cyst excision. So what are the clinical applications of robotic surgery in pediatric population? It can be used in various surgeries. Begin with the thoracic and neonatal surgeries like diaphragmatic hernia repair, which can be both transthoracic and transabdominal approaches. Tension-free closure can be done without the use of a mesh. Esophageal atresia, robotic thoracoscopic anastomosis was done in a 3.2 kg neonate, operation time of 95 minutes. Congenital lung lesions, pulmonary resection can safely be performed at the age of 6 months. Abdominal and colorectal procedures, Hirschsprung's disease robotic pull-through procedures can be done. The advantage is the learning curve is short compared to conventional laparoscopic surgery. Functional recovery is faster or better comparable to laparoscopy with reduced pain and enhanced cosmesis. Pediatric urology, minimally invasive excellence, 94% of reflux resolution rate in robotic reimplantation for VUR, and 96% pyeloplasty success rate. Low conversion to open surgery, less than 10%. So we'll be demonstrating a video of pyeloplasty. You can see there is a crossing vessel over there. So the pelvis is, PUJ is being disconnected. Already the stent has been placed before the procedure. This is the dismembered Anderson-Hines pyeloplasty. So we have spatulated the ureter. In laparoscopy, this is a very challenging part, the intracorporeal suturing, especially a ureter which is hardly like 2 to 3 millimeter in diameter. Posterior layer, the angle is fixed and then the stent is placed into the pelvis. Then the posterior layer is continued. Then the anterior layer of the pelvic pelvis and ureteric anastomosis. Reperitonealization to cover the anastomotic site. Another very complex reconstructive surgery what we do is the ileal mitrophenoff, done in children who with neurogenic bladders who require CIC. Doing a CIC paruretrally is painful and children may not be able to do. So we do this ileal, we use the ileal segment and attach it to the bladder with the anti-reflex mechanism and bring it out either near the umbilicus or through the right iliac fossa so that CIC can be done safely. Bowel segment is being harvested. These are maneuvers to bring the bowel down as far as down into the pelvis. The intestinal continuity is being established. We use the Sure Form robotic staplers. Hardly takes about 30 seconds. And the cavity open segment is closed with another stapler. Now the harvested segment of the ileum is being laid open. We tailor it over a catheter, maybe like 12 or 14 French catheter, so that can be used. We reduce the lumen to that size so that it can be used for CIC. So the ileal tube is ready. Next we drop the bladder. Bladder is being filled, and then we open the detrusor and make a detrusor tunnel. So this provides the continence mechanism for the mitrophenoff. About 3 to 4 centimeter long detrusor tunnel is made. The ileal tube is placed, and then the detrusor muscle is wrapped on top of the ileal tube. So these reconstructive procedures take quite some time. You need to have a lot of patience while doing these procedures, unlike the destructive oncological procedures. The tunnel is important because otherwise patient will keep leaking the urine through the conduit. Now the other end is being brought near the umbilicus. It will be brought out. Stent. All this takes a lot of innovation on the table adjustments. Releasing the mesentery so that the tension on the tube is reduced. This is the appendix being brought out for the MACE procedure for the antegrade continence. Next, this bilateral ureteric reimplantation done in a child for bilateral vesicoureteric reflux. The left ureter being mobilized. The right ureter is being dissected. So once the ureter reaches the bladder, it is disconnected over there. We had put in a stent for this patient prior. We could get the stent across only on the right hand side for easy identification. Now the bladder is being opened. The reimplant can be done either extravesical or intravesical. In this case, we are doing intravesical anastomosis. We create a mucosal tunnel. That's a mucosal tunnel being created on the left hand side. it's quite tricky to create just the mucosal tunnel. So once the tunnel is made, we pull the ureter underneath. The ureter is pulled and then anastomosis is being done. The tunnel where the ureter is entering, that mucosal defect is closed so that the reflux chances are minimized. Same procedure is being done on the right hand side. Again, the mucosal tunnel here. Compared to extravesical anastomosis, intravesical anastomosis is little challenging and time consuming. Stents are being placed on the left hand side and then on the right hand side. Stenting the right ureter. Finally, the bladder is closed. Next procedure I'm going to demonstrate is the bladder neck reconstruction. We do it for children with neurogenic bladder with incontinence. Before this bladder neck reconstruction, we have to reimplant the ureters. If the bladder capacity is small, we may have to augment the bladder, and then we create a mucosal flap starting from the bladder neck, about 3 to 4 centimeter, about 1.5 centimeter wide, and then tubularize it, and then denude the mucosa on either side of this tube, and make a flap wall using the walls of the bladder. The bladder is opened vertically. Prior to this, we would have done the reimplant of both the ureters. Then we make a urethral bladder mucosal tube for about 3 to 4 centimeter, about 1.5 centimeter wide. A 10 or a 12 French catheter can be placed, and over that we tubularize the mucosa. So once the tube is created, we take out a patch of mucosa on either side of this tube, and then overlap the flaps of the bladder. So the mucosa is being denuded over there. The bladder would be closed like an ice cream cone, wrapping one wall over the other. So that provides additional continence mechanism. catheter in place, and then rest of the bladder is closed. So another reconstructive procedure what we commonly do is for small capacity bladders is augmentation cystoplasty. Again, small bowel is harvested. We take about 8 to 10 centimeters of the bowel, about 15 to 20 centimeter away from the ileocecal junction. Intestinal continuity with the help of show form staplers. The harvested segment is opened, then the bladder is filled and bladder is opened. You can see the bladder is quite thick and trabeculated. It's a small capacity bladder. SPC being placed, because there will be a lot of mucus production, so we need to give bladder washes. So what are the current challenges and barriers in robotic surgery in pediatric patients? One is the anatomic space constraints, specialized training requirements, high acquisition and maintenance costs, and need for long-term data. Future innovations, next generation miniaturized robotic instrument that is 3 to 5 millimeter, which can be used safely in infants also, and enhanced haptic feedback integration for delicate pediatric tissue handling, expanded single-site robotic platform for scarless abdominal interventions. Currently, a procedure known as hidden incision endoscopic surgery is being performed for pyeloplasty and reimplants. So that is the scar you can see in Hyde's pyeloplasty, where there is a single scar about 1 to 2 inches, which can be easily hidden under the clothes. And AI image overlay guidance and AI automation will help in better surgeries for the infants also. Thank you.
Thank you, Dr. Basraj, sir.
Any
for
questions?
Any
Thank
questions from the delegates?
Thank you.
Okay. We now move on to our final interactive session. That's reconstruction made easy through Robo. This panel synthesis will bring together dexterity, 3D vision, and intracorporeal suturing, advantages across prostatectomy, cystectomy, and pediatric reconstruction. I welcome Dr. Shreyas to take over the podium.
So mine is the last talk of the evening. I'll keep it very short and sweet before we go in for a tea break. As you know, the advantage of robot is your colleague can take over the surgery easily when either there is a fatigue or you find a difficulty. This is my role because today was not my topic, but my colleague is stuck in an emergency. I'm doing the topic today. So I'll just be speaking based on the experience of what we do. The agenda is basically to show the range of work we do, what is the armamentarium which we have, and I'll not go into the technicality which has already been covered throughout the day. So the topic is mainly reconstructive urology. For any reconstructive urology is an art, which is a skillful surgery which has to be performed at precision. It is because basically we have to maintain the vascularity, the fibrosis of the tissue which we find has to be tackled, and the anastomosis or the reconstruction what we do has to be apt. so that the functionality is recovered. So that is the main aim of reconstructive urologist. So as we have evolved from an open era, then we came into the era of laparoscopy and then the robotic. Though the laparoscopy and robot are very similar, both are keyhole surgeries. Laparoscopy used to take a lot of time, more stress on our shoulders when we used to operate for a long time. Robotic surgery advantage being we sit easily on a console and we operate at ease. The dexterity of the movement which we do with the arms of the robot, suturing has been very easy. So as we said, it is beyond the rotation of the human hand. It has more than 360 degree of rotation. As many of the videos have shown, the ease with which we can do the reconstruction and the magnification with which we do. Each vessels which we see is accurately coagulated. We don't damage the surrounding structures. The precision has been excellent. So the additional armamentarium in the robotic console or the system is one thing which is called an ICG. What is ICG? Is like a torchlight which guides in the darkness. ICG is basically used to identify structure which is otherwise not able to identify. When there is a scarred tissue, you can't identify the ureter. How do? We insert this material called ICG. It is basically a dye, and we have a system which will illuminate this ureter when we are dissecting so that the ureters can be isolated. It has multiple roles. This is the topic of me which I'll be speaking in specifically tomorrow, ICG in urology. So the core challenges, as I want to say, is one, the well vascularized anastomosis, because when the vascularity is lost, the anastomosis will leak. So the tissue doesn't take up. It has to be tension free. Mucosal to mucosal anastomosis, that is the basic of any surgery. Either it is open, laparoscopy or the robotic. These are the basic principles of a surgical practice. So the challenges is common for any of the reconstructive surgery, being the ischemic tissue, because these tissue are the cause for the problem, the fibrosis which has already set in, and mainly the narrow retroperitoneal spaces. So why robot? Why not open? Why not lab? Why robot? I think the entire day has been for the robot. So it is the precision, basically, it is the dexterity of the motion which we have, helps to identify each structure, the blood vessels are seen, and seamless suturing. So the surgical spectrum of reconstructive urology, which a robotic urology surgeon does, starting from the upper tract, that is from the pelviureteric junction, which can be an obstruction, especially in the pediatric population, which is already covered, or the ureter can go in for stricture. Stricture is basically a narrowing in the passage, which will cause an obstruction and also cause pressure in the kidney. And what happens over a period of time, the kidney can get damaged. So we have to reconstruct this so that a seamless passage of urine occurs without any obstruction. And the same obstruction can occur lower down in the ureter. The entire length of ureter can go in for narrowing at any part. Reasons can be different. In adult, basically stricture. The reasons for stricture can be previous instrumentation, or any history of radiation, or history of any damage during any gynecological surgery or even a urological surgery. When you come to pediatric, the vesico-ureteric reflux, neurogenic bladder, which is already covered. Pediatric population, again, congenital anomalies, and other things, as I said, radiation, strictures, and retroperitoneal fibrosis. So ureterocalicostomy is basically a surgery which is done when there is a narrowing in the upper ureter. Just a minute. So this is how your colleagues help and take over. So the advantage is ultimately the outcome is what it matters. You can play directly. Yes. Playing.
ಪ್ಲೇ ಆಗ್ತಾ ಇಲ್ಲ.
Okay, the previous video. This is done. This is done. Yeah.
Next video.
Yeah. Okay. So what is ureterocalicostomy is basically when there is a narrowing in the ureter, especially a long length upper ureter, when we can't anastomose the ureter to the ureter, or when we can't use in a segment. This is the ICG, which we are saying. See the illumination, how it is picked up. That is the ureter. Because when there is so much of fibrosis, identifying ureter itself becomes a great task. So with this material, you can see how we switch from a normal vision to the ICG. It is basically a firefly technology is what we say. So when there is a narrowing in a long length of ureter and we can't anastomose to a pelvis, when the pelvis is also scarred, then we use something called a ureterocalicostomy. Basically, the calyx which is there in the kidney, we open the kidney up and the ureter is directly anastomosed to the calyx. How do we do? Yeah, this is the kidney. Can you see? Yeah, this is the kidney which is opened up and that is the calyx. And the ureter will be anastomosed directly to this. So we entirely bypass the pelvis, which is a scarred in this case. So the principle of everything else is same. The stent is put, which is kept for 6 weeks for the anastomosis to take place, and the ureter then anastomosed to the calyx. So the principles is same. So ileal segment interposition is another a very tough surgical procedure. When the entire ureter is scarred, what next is the option? Where we use a segment of ileum to reconstruct the entire ureter. This ileal segment is used from the kidney. Either you can anastomose if the pelvis is fine, or again to the calyx as I've shown. And the lower end of the ileum will go into the bladder. So the ileum will do the work of the ureter. This is again the firefly or the ICG technology what I showed. So this is opening of the lower calyx. Directly we make an incision onto the kidney, identify where the calyx is. The advantage, one more, is we can do a scan on table, ultrasound scan, which is a drop-down ultrasound probe. If we have any difficulty identifying, place an ultrasound. On table we do an ultrasound to check where exactly we need to open onto the kidney. Take an ileal segment and the upper part will be anastomosed to the kidney, and the lower one, yeah, this is the ultrasound probe what I have told you. So what we also tend to do is we'll identify the blood vessel of the kidney, clamp the vessel, because there can be, kidney is a highly vascular structure. Bleeding is one important thing. So we need to control bleeding before we do anything. So we identify with this ultrasound, we get a real-time image of the ultrasound. We know where exactly we need to open up. Clamp the artery before we do the procedure. Isolate the ileal segment, which was all shown previously in most of the surgery, and then reconstruct. I will not go into the entire video. So these are the different options which I have told. If the, again, how do we choose a surgery depends upon the length of narrowing. If the length is very small segment of narrowing, the ureter to ureter anastomosis can be done at ease. But if the length of narrowing is large, there are different techniques. If it is a lower down, we do a ureteric reimplant. We do something called a Boari flap, where a wall of the bladder is created into a tunnel and the ureter can be anastomosed. There are different techniques of doing it. If there is a larger piece of ureter which is strictured, we use the ileum, which was shown in the videos. So these were the thing. Again, when we do anastomosis, these are again a few technical nuances called a Soya stitch, where we need to bring in the bladder slightly up so that if there is too much of tension, so the ureter and the bladder anastomosis can be at ease. Boari flap, as I have told, we will create a tubularized flap using the bladder. BMG ureteroplasty is another excellent procedure. What we basically tend to do is, Everyone have heard of buccal mucosal graft urethroplasty. Urethra is basically the passage where we pass urine. When there is a narrowing, we use this buccal patch. Same principle is followed here when there is a narrowing in the ureter also. A buccal patch is taken. Wherever is the narrowing, that segment of the ureter is opened up. We put a patch of buccal mucosa onto that and a omental wrapping is done. So this is one more important technique which can be used. So again the principle is same. Identify the ureter which is narrowed down. Once that portion of the ureter is identified, we open up the ureter. Once it is opened up, we would have already harvested a segment of the buccal mucosa which has to be harvested. This is the ureter which we see. We loop it up. Once it is looped up, then we tend to open the ureter. The suturing has been so easy. With laparoscopy, the suturing are difficult because the instruments are all straight and suturing is very difficult in such reconstructive surgeries especially. That is the advantage of robotic surgery. As we see, we tend to open the ureter, that is a strictured part. Opening also will be difficult because it is all fibrosed. Once we open it up, we would have already placed a stent there. Stent is basically for the anastomosis to heal. And this is a buccal graft which is harvested. And the entire buccal graft is sutured to the length of ureter which is opened up. So once this is done, we leave the stent for at least 6 weeks. After 6 weeks, the anastomosis would have taken up very well. So as I reiterate again, the main aim is to maintain the vascularity, which becomes very important. A tension-free anastomosis for all this to work, and a good anastomosis. Yeah, I'll just skip the video. So I think this has already been discussed, pediatric reconstruction, what the role was and what are the conditions. The vesico-ureteric reflux was one, megaureter was one, PUJ obstruction is one. Redo surgery, radiation. So this is a very important challenge for a neurosurgeon because everything will be stuck. Identifying the planes become difficult. And again, opening and doing the surgery, the advantage will be a big scar. Recovery of the patient will be difficult. With minimum keyhole, if you are able to finish it, the recovery will be at most. So the answer is robot. Identify the structures. Because of the armamentarium which we have the ICG, we have the intra-op ultrasound, the ease of suturing, all that will result in a successful outcome. Vesicovaginal fistula is one common problem which is encountered by the urologist, gifted by the gynecologist. So what basically happens is, it can happen to anyone. The ureter can tend to get damaged, especially during an hysterectomy. Either they tie it off completely or with thermal injuries. And there can be an fistula which would have developed between the ureter and either with the vagina, or the ureter can directly open up with the vaginal, or the bladder with the vagina. So the aim will be to identify the problem first with a CT scan. CT urogram picks up, patient comes with leaking of urine from the vagina, or she'll have urinary incontinence. So basic principle will be identify the fistulous tract, open it up. This is a vesicovaginal. Vesicovaginal is basically between the bladder and the vagina. So separate the bladder from the vagina, identify where the defect is. Once the defect is opened, close the defect. It should not recur. So what we can do is we patch a piece of omentum between this so that it doesn't recur, and reconstruct it. The advantage being the ease of suturing and the ease of identification. I'll just move on with that. Retroperitoneal fibrosis is another challenging condition where the fibrous tissue engulfs the entire length of ureter and put pressures on the ureters. Basically, we have to release the ureter from this fibrous tissue. The procedure is called ureterolysis. The entire length has to be freed. Once these ureters are freed from fibrous tissue, a womental wrapping has to be done. ICG is the intraoperative innovation. Tomorrow I'll be talking about the same topic in detail. So ICG, as I said, it is basically a torch in a dark place. So there are different roles of ICG. Coming just to the reconstructive urology, it is basically to identify the ureter, identify the vessels, and know exactly where the structures are when there is fibrosis and adhesions, and use this technology so that you can prevent damage to the surrounding structures and identify the structure which you want to see. It gets illuminated like this. When we see a standard, we don't know where we are, where the ureter is. So when the ICG is injected, we can clearly make out, okay, this is the ureter, this is where we have to dissect it up. So there are different anatomical problems like a horseshoe kidney, duplex. Again, these kidney can have different tissue. There can be a PUJ obstruction, there can be a vesicoureteric reflux. The principal surgery remains the same. The complex other, I think already this has been done, an augmentation cystoplasty and mitrophenol both has been talked. So the role and the varieties of usage again is vast. Augmentation, cystoplasty, ileal vesicocystostomy, there are different roles which the robot has been serving us. Again, with the innovation, many different techniques, multiple port to single port. Those also reduces the number of scars, number of entry point, a single point of entry and a multiple instrument open up inside. So what we want at the end with this surgery is basically the outcome, minimizing the risk, enhancing the outcome. A successful surgery basically depends on multiple factors, one being a smaller incisions, early recovery, early return to work, good outcome. That is what is expected. With the robot, the complication rate definitely has come down. So that is the important point. So the future has already been told multiple times, single port surgery with the invention of AI, artificial intelligence, which has been playing a very important role. Augmentation, reality, artificial intelligence, especially when we do a partial nephrectomy, the entire image is reconstructed 3D. Before we even go into the surgery, we know what are the feeding vessels which go into, where we need to dissect, how much we have to limit our level of dissection. So such is the ease, again with the use of ICG and ultrasound probe, know exactly to limit the level of dissection, preserve the kidney. Nephron sparing has been the protocol now for partial nephrectomies. So conclusion, evolution, precision, versatility, and patient-centric. So this is the topic, this is the conclusion, and that is the main principle, what we expect and the outcome. Thank you so much for patient listening. Thank you. Any questions I would like to answer?
Thank you, Dr. Shreyas, for comprehensive but detailed talk on reconstruction made easy through robo. As we reach the conclusion of Urological Robotic Surgery Symposium, I would like to thank all our clinical coordinators, the presenters, and the delegates. We'll break up for a tea break session now, and we'll reassemble for the next session that would be on minimal access surgery in Hall 3. Thank you. Please take a moment to give your feedbacks, write your feedbacks on the feedback form, please. Thank you.